Well, this is our presentation, Stroke of Bad Luck. This is our interprofessional Team 10. My name is Jackie. I am a nursing student, and here we go. Okay, that's not working. All right, so we all know the charge. The charge is we want to involve local and regional institutions and community resources that utilizes the interprofessional teamwork to enhance the care, to enhance the process of care to ensure patient-centered outcomes. We wanted to look at this through the triple aim theory. We wanted to go through the experience of care, health of a population, and do all this by reducing cost. So when we first started out with looking at this case, we wanted to analyze the case, and as with anything in healthcare, we wanted to do an assessment. So we did this through the SWOT analysis, looking at strengths, weaknesses, opportunities, and threats. So our first is our strengths, and we did this by looking through the regional, local, and then coming back to Lynette's case. First is strengths. The strength in this community is that they already had the stroke-related initiatives set up. They had the Medicaid expansion programs. They had the signs and symptoms for stroke already out there for the community. And then coming back to Lynette's case, her strengths were her family and then her involvement within the community. Coming over to weaknesses of this region were limited care coordination. The coordination from care from facility to facility had room for opportunities. Also, distance between care and the culture of this region was don't seek care until you absolutely need it. Coming back, also underutilizing the education and those kind of programs that were already out there. Coming back to Lynette, her weaknesses were that she was not very proactive about her health care and that she had no health insurance. Looking at the opportunities that we wanted to look at was the University of Kentucky. Utilizing their education, their students, maybe setting up something where their students can do free screenings. Also, the South Tree Health Network was already in place, and the Medicaid expansion. Coming back to Lynette's opportunities, she finally did get the health insurance that she needed, and just her family involvement. And lastly, looking at the threats. The threats of this region was the economic factors. Perry County was in the top 10 distress in the United States. Also, the non-compliance of the culture, and there was no medical school nearby. Coming back to Lynette's threats was that she had no proactive care and no insurance, and then she did not qualify for the Medicaid expansion. So after assessing this whole case, we wanted to look at it through three lenses with our professional team here. First was enhancing the patient care experience in the inpatient care, like hospitals. Improving population of the health, so looking at our community and moving towards a proactive instead of reactive model, and by doing those two things, reducing the cost of healthcare. Through the three lenses, we always want to come back to Lynette's story and give you an analysis of how we want to change her process of care.
Good morning. My name is Shivani. I'm a first-year medical student, and I'm here to talk to you a little bit more about how we think we can enhance the patient care experience. So first and foremost, in looking at Lynette's care experience, we decided we wanted to address the issue of developing clinical and rehabilitative care pathways. For a more comprehensive list of measures that we think would be effective in developing such a pathway, consult the appendix. However, in looking at her care, we want to create a clinical pathway so as to create a standardized quality of care, begin identifying any further bottlenecks in the care process, and to overall reduce the cost of care for treating each diagnosis. In addition to this, we want to ensure we're taking a very interprofessional approach in providing care, and in doing so, in creating these pathways, we want to make sure we're consulting with all the relevant healthcare professionals. Additionally, in providing care, we want to make sure we're identifying in-house personnel who are responsible for patient follow-up. We want to make sure that these in-house personnel are meeting with the patient prior to discharge and following up with the patient regularly after discharge, in addition to performing a 6-month quality of life assessment. In addition to that, we want to ensure that we have community health workers who can hold our patients responsible for their health. And Jen will discuss this in greater detail later in the presentation. And last but not least, we want to make sure that we're improving interdisciplinary and interprofessional communication across all facilities within the South Korean Health Network. And we want to make sure we're incorporating the patient as a member of our care team. Something we noticed as we were going through Lynette's case is that there were numerous missed opportunities for communication across the facility and between healthcare providers within one facility. And our method for addressing this involves creating checklists that will be used throughout the care process. And not just any checklist, but very much communication-driven checklists. In specific, as I mentioned, we want to ensure that we have these at every transition between facilities, as well as between providers internal to the facility. Some components, possible components to the checklist include ensuring that we're communicating the patient needs to each subsequent facility. If we think that there's something in particular that the patient may need at some point, we want to make sure that the next facility is aware of this. Additionally, we want to ensure that we are talking to our patient and identifying what our patient's goals are for their own treatment and addressing how we think that we are going to achieve these goals for the patient and constantly reviewing this plan. Additionally, we want to ensure that each time we move our patient from one facility to the next, check again to see if there are any needs for the patient that were not addressed or any that need to be readdressed. And last but not least, we want to ensure that we have a list of standardized metrics that we can use to track patient progress throughout this care process.
I'm Nick. I'm the health administration student for our case. When we look at Lynette's case, there were various missed opportunities to provide coordinated care for her. So the kind of what Shivani talked about, we want to include standardized care pathways and checklist-directed communication. But more importantly, we also want Lynette to be part of the care team. We want her to become part of the decision-making process. And if you look at the case, most of the time she's just being told what to do, and then she's supposed to show up to her treatment, which goes to the next point of ongoing monitoring after discharge. Does that really happen? Not really. Like I said, the onus is on her to get to her treatment, and there needs to be more bidirectionality in the communication so that she can actually get the treatment that she needs.
Hi, I'm Jen. I'm also a first-year medical student. So we kind of looked at how Shivani and Nick talked about how we can better improve the patient experience at the hospital level. Now we want to talk about how we can improve the patient experience at the population level and work through some preventative measures. So by doing this, we'd like to set up a community wellness program, similar to those that we've seen across the United States pop up, whether it be at a small level or a local level inside of the community. So this community wellness program will work with the community to provide screenings and healthy educations, various different resources that the community can use to get their blood work done or get education to learn how to eat better or have a healthier lifestyle. And we want to work with small businesses and community members to create an insurance program that offers lower premiums for these healthier lifestyle initiatives. And by doing this, we feel that we'll create a healthier community with lower risk factors for stroke, educate our community members, and then also decrease the cost of hospital spending by either going to the hospital in the first place or readmission rates. And an example of a community wellness program that we kind of used to look at was the Centegra health system in Illinois. So like I've said, we've seen these community programs pop up all across the United States. And an area that we feel could be improved is the use of what we title as community health workers. So bringing people from the community into our system, hiring them. As you may have read, Perry County has a very high unemployment rate, so we're kind of tackling this also. And so hiring these community members, whether it be the person who's very involved in the church or the busybody who knows everyone and loves to get coffee with everyone, someone that the community feels comfortable with. So hiring them, making them an advocate for our program, going up to the friends that they have or the people in their community and saying, here's the program that's in place, here's ways that you can obtain a healthier lifestyle, making sure that they get to their screenings. Also encouraging and engaging the community through support groups, leading these support groups and really bringing the community together so that they can build a healthier lifestyle as a community. Finally, we understand that this is a low economic area, so they may not have access to internet or computers, and making these community health workers as a hub where they can go to the community member's house or a coffee shop and use the internet and the computer to access their patient portal that we hope to utilize through our electronic health system. They can access their charts, doctor's notes, education resources. So by doing this, we hope to combat both the unemployment in the area and also reach the community from within. Rather than just a bunch of health workers preaching from above, we feel that we'll be able to really encompass the whole community.
All right, so coming from what Jen was just talking about with looking at the community, and coming back to Lynette's story, this is where we want to incorporate those health workers when she is on the patient follow-up side and then up to the preventative side. We want to get these community health workers involved, even if it's just to call her and say, hey, Lynette, have you talked to your doctor? Have you had a follow-up appointment? Do you have any questions? Because if you do, I can connect you with somebody that can answer those questions for you. Just helping to empower patients to really care about their health. And also, we hope with this it will decrease the stroke risk in the community.
Now, the third component of the Triple Aim approach is reducing the cost of healthcare. And I think what ends up happening with a lot of people is they think we can actually make medical treatment less expensive, but the reality is with inflation, you can't. So we need to focus on reallocating our resources elsewhere to prevent, the need for medical treatment for stroke in the first place. And we believe that there are two ways really that can help us do this. First is insurance reform. There are some arguments saying that insurance reform won't work in these type of communities, and I would argue that it can, and Lynette is a great example. Lynette is someone that didn't qualify for Medicaid. She didn't like the Affordable Care Act, but yet she still bought insurance off of the exchange. So one way or another, people can be insured. And what this means is she now has access to preventative services. As we know, preventative services are now in every health plan in the country as part of the 10 essential benefits that every health plan has to offer. And then along with that, patient satisfaction and readmission penalties for Medicare and Medicaid patients has been a pretty large component of the Patient Protection and Affordable Care Act that could actually have a positive influence for people like Lynette who had to keep coming back, and their patient satisfaction would be lower. The second component, as we talked about, the community health workers. The idea with this is that if you can reduce the cash flow to a traditional model and you can reduce direct medical cost, then you can probably decrease out-of-pocket expenses because you have maybe a higher short-term investing in preventative activities that are going to promote healthy behavior and have screenings, for example. But you're going to decrease those out-of-pocket expenses, and you can actually make healthcare cheaper. So going on to the next slide, this is just a comparative analysis that we put together, taking the traditional model and comparing it to an experiment that the CDC conducted that looked at the cost effectiveness of community health workers in a rural environment. So when looking at the traditional model, the average total cost of treatment per stroke case in the United States is $54,000. That's $35,000 of that is direct medical costs. And when you look at the traditional model, it's fee for service. What we want to do is we want to implement more of a bundled payment system that really takes on the approach of value-based purchasing. So we clearly have to move away from this traditional model. It's getting too expensive, particularly for people like Lynette. And even if you have insurance, costs just keep on piling up. So just to explain the experiment that the CDC ran, they wanted to take a more proactive model with the use of community health workers. And so they hired 3 community health workers to cover 27,000 people in rural Vermont. The total cost of the program for 1 year was $420,000. Keep in mind that this project was only a 1-year deal. The actual program cost per worker was $140,000. And so if you were to do the math, for 3 people to cover 27,000 others, it's $15.57 per life. And if you were to increase that population service area, that number actually goes down. You're actually spending less per life. Now, yes, this could be cost effective. Does this affect quality? I'm not sure, and the research says that as well. What you'd have to do is you would have to take a decade-long or a two-decade-long project to actually compare the quality outcomes with the cost effectiveness. But I do believe that but I think that most importantly what this shows is that if you can reallocate resources, to take more of a comprehensive and proactive approach to improving the health of people, you can actually save a lot of money. And I think this is definitely approach, and I think we all can agree that South Street Health Network has to do something in terms of shifting cost. We believe that this is a definite possibility where people can become healthier and we can actually reduce the stroke incidence rate in this area.
As Nick mentioned, Lynette is a prime example for why insurance reform can work. Initially, at the beginning of the case, she did not have insurance, but she did eventually purchase insurance off of the exchange. Additionally, if she had had this insurance in the very beginning, and if she was a part of our community wellness program, her treatment would have been covered. We could have possibly prevented some of her secondary conditions, and ultimately, if she were to follow through each portion of our program, it's possible that we could have prevented the stroke in the first place.
So after presenting all of these options that we have through the triple aim, I'm sure you're wondering, how are we going to measure if this is actually working? And one of the things that we wanted to use is use the systems that are already in place, such as those from the NQF or the NQMC, and looking at stuff such as our charts being completed, our readmission rates going down, our medications being fulfilled, and our people really knowing how to take their medications. And by using this, we can evaluate, is our coordinated care system working? Also, we want to look at we want to implement a system-wide performance dashboard. So looking at different vitals, different blood work, again, the readmission rates to say, is the stroke risk in our community really going down? Are readmission rates really going down? What improvements can we make to better educate the community? And finally, for the prevention and care side, we want to look, are the stroke risk factors really going down in our area? Are more people being insured? How can we include more small businesses or community workers into our program? And so we want to look at this every year for about 5 years at first to reevaluate what ways that we can improve, what ways we can maybe enhance the education, fix little aspects in the community workers, and get more businesses and more people involved in our program.
So just to recap, we have taken each component of the AAA model and we have come up with a comprehensive solution in order to reduce the stroke incidence rate in this area and to help people like Lynette actually take control of their life and avoid some of these financial burdens that she went through.
Any questions?
Any questions?
So I'm curious, what kind of data infrastructure do you think we'll need to put together that data dashboard? Because we were pulling data from a lot of different sources, and some of it was data you're going to have to go get.
Right.
Some you can be pulled from other sources. So oftentimes organizations are challenged, especially big community organizations, by integrating data in some kind of useful way.
Yeah.
What are the costs associated with that for our network?
The costs or the ways that we're going to?
I guess both. It was sort of a two-part question. How would you address it, and what do you think it would cost?
Okay, so one of the ways that we want to get the patient data is through the patient portal that we'll be using. So all of their information will be stored through the patient portal, both in two parts so that they can access it and so that we can easily access it to look at the different changes, such as the various screenings that the community members will go through, looking at different points, is their blood pressure going down, and then compiling that data. And then also in terms of the readmission rates, looking at times that the patient has to come back through the hospital through the health administration.
In terms of cost, it really depends on what EHR you want to use. It seems to be that the most common is Epic. I know from a provider that I won't say, that for a MyChart portal, they have an annual payment of $45,000 a year. And so, but that also brings in a lot of meaningful use revenue. And so I think what you'd have to do is you'd have to look at the size of your system and how many people you're trying to serve. And then and depending on how big, Epic assesses South Street network, South Street is, and what revenue they can actually bring into Epic, that's when you can negotiate a price point to the actual cost of putting something like this together.
Thank you.
You really didn't address exactly what the risk factors of stroke were. Wondering what specific things you would recommend to tackle first as it relates to the health of Lynette. So we know that some of the risk factors relate to blood pressure, lifestyle, exercise, and that. So how do you propose getting down to the nitty-gritty? You've talked in general about what you would do with your community health workers now, but what would we get down and really work with our patients on?
Something we realized in looking at the case was that the South Korea Health Network, a lot of the facilities were already offering a lot of these programs that were very pertinent to health improvement in general wellness. And so we really just hope to connect our patient network to infrastructure that's already existing. For example, even as part of our community wellness program, I mean, we were discussing the idea of like having support groups and connecting folks to weekly recreational activities or even frequent screenings that we could do. So begin to identify folks maybe who have high blood pressure and bring them in, maybe suggest interventions for them. And again, if we have support groups that really hold people to walking a few miles a day, I mean, that can make a big difference.
And it seems like in this community, they already have the initiative set up and then they have the patient. But there's kind of a disconnect to get the patient to those, already in place initiatives. And so that's where our community health worker can be involved and be the link between the two and just give her the information that it was there and just provide that.
And also through our program, for example, like a nutritional program that would encourage a lower sodium diet, healthier choices, and as community workers, they can kind of set up ways that, or foods that at their local market they can get, because sometimes in a lower economic community you don't have something like a Whole Foods or a Trader Joe's or something like that where they have organic or healthier options, and a lot of people are eating more processed food. So really getting people to eat more fruits and vegetables, and really having the community worker be that person that helps with that. And also we noticed that they have a gym at the high school or the elementary school, and potentially using that to open it up for community members in the evening that it's not being used by the school. So really setting up resources that the community members can go to if they if it's cold out and they don't want to walk, just little things like that. Does that answer your question?
One of the challenges is that you've got a hospital, you probably have physician groups, you have insurance plans. One of the challenges is how do you go about engaging the hospital and physicians who might be at odds on how to do things, and along with the insurance company?
We talked about it very briefly, but Centerga Health System, it's in McHenry, Illinois. They're a great example of how they've taken a community, they've taken all the different components, the different siloed components of their health system, and they've integrated it together. So a lot of it is just bringing people to the table and creating buy-in, right? That's more of an organizational behavior issue. But Centerga Health, they offer fitness, as a hospital. I mean, the key is to make that first step as an organization. And I think we can all agree that that's really hard, because when you consider different stakeholders, everybody has their own initiatives that they want to accomplish. For physicians, it's their practice, right? If you can somehow bring people together, that's how you're going to create an integrated system. You've got to create buy-in.
One question. It seems like in a region of the country that has such a high incidence of stroke, that a huge part of the cost of taking care of these patients is dealing with their post-stroke morbidity and mortality. If you mentioned this, I missed it, but what do you think about acute intervention with stroke as far as saving the community resources and improving patient outcomes? I didn't hear any mention of that. How do we get patients to TPA sooner? How do we do we need to develop a comprehensive stroke network, which maybe this region doesn't have? What are your thoughts about more timely intervention with a patient that actually has a TIA or a stroke, an MRI that shows a density problem?
I just want to before they get going. I think that the big thing is recognition of stroke, and that comes through education. I mean, how many people did Lynette run into before people realized that she needed to get to the hospital? And that's where the community health workers come in, and that's where proactively, not just proactively where people can take care of themselves, but they can recognize the signs for other people in their family. That's where the community health worker comes in.
Yeah. Coming off of what Nick said, me being from a small town, I can tell you the hardest thing would be to change the culture, to get the education out there. And just maybe even having as simple as having signs up of what stroke looks like in local churches, banks, just small businesses all around, just getting the word out there, even word of mouth. And that's, again, where we want to get these community health workers in the system, in the community, out there just advocating for what a stroke looks like.
And one of the things that we recognized was that, for example, the UK system is many miles away, and I believe there was an urgent care that was right there that Lynette could have gone to. So potentially setting up more resources at that urgent care that can better acutely treat stroke before sending them to the hospital. Just because since it is so far away, you're right, they're waiting longer time to get that TPA to better their outcome. So once they're recognizing it, setting up more transportation services, whether it be through the community health worker or through family members, and once they're better able to recognize, get to that urgent care better, and then if we have the resources at the urgent care, that they can better get treated faster.
And as Jen mentioned, the transportation is a critical part of that. And I think in Lynette's case, an ambulance transported her to the hospital facility. And so we want to ensure, even in that facet, we're making sure we're bringing these people to the table too and saying, look, you play an integral role in this process, and here's what we're going to need from you, and helping them, again, identify the risk factors and maybe contact the hospital in advance saying, this is what we're seeing in this patient, so that there's a level of preparedness there.
I think, too, that there are also cheap forms of marketing that you can use that actually takes more of a population health approach. For example, billboards. I mean, I've driven past billboards, and these are the signs of stroke. Imagine if you have several of those in that town, or you have, however many number you can have in that region, in that county. I mean, that is a great, inexpensive way to actually market the signs and to educate people.
This is an interesting example of the lack of community education. Here, a son takes her to urgent care. Most urgent cares are not going to do acute stroke intervention. They're going to want them to have a head CT first before they get TPA. So in a rural area of Kentucky where there's a lot of mountainous terrain and so forth, you've got to have an intact, solid EMS transport system that's willing to deal with rough terrain and so forth. And I think the community education, community educated enough through billboards and other things would know if you have a patient with TIA, stroke symptoms, you don't go to urgent care, you go to a regional stroke facility or comprehensive stroke facility. And if one of those 4 hospitals sees a patient and they can't deal with it, or they have a poor response to TPA, they get airlifted to the University of Kentucky.
That's all the time we have for questions. We're going to do 10 minutes of feedback.
You're going. Great presentation. You clearly put a ton of work into it. Your slides are fantastic. It looks really good. I just wrote down a couple of questions. So just one thing, a point of feedback. I thought that you didn't flesh out the finances well enough associated with what was a big piece of your proposal, the community health worker. And like in the example of the study that you cited with 3 workers one per 27,000 lives, and that was $140,000. And at the level of interaction you're talking about, like helping people with, it sounds like a very personal interaction, and that ratio doesn't really work, like 1 to 27,000 helping people with nutrition. And so for $140,000, if you started making those numbers smaller, it would be a really expensive intervention. And whether that really, and even the study says it, whether that gets us the kind of preventive numbers from a population health metric perspective, I think would be in question. Another thing I really liked was you sort of led with low-tech solutions. It's tempting to move to integrating EHRs and really expensive things, but you were talking about some basic communication things that could be done very inexpensive in a system, checklists and, pathways and standardizing care and things that involve a lot of work and a lot of integration, but they're not necessarily super expensive. I thought that was a real strength of the presentation.
Great presentation. I know this. I thank you, because I can't imagine the amount of time, work you put into this. I, as background in cardiovascular surgery, would think it would strengthen the presentation to deal the two components of this that might have added some strength. One is the treatment, acute treatment of patients with TIAs of stroke, because if we can intervene earlier, the morbidity on the outflow end is going to be lower. The second thing is just the huge cultural issues here, and I think you've done nicely. I think it was a strength of your presentation about how you talked about community education and so forth. There was no mention, however, of the cultural norm in this region of the country of resistance to medical care, not trusting the healthcare system, not wanting to be involved with physicians. And as we all know, changing culture is a huge, long process, but it might have been interesting to have you expand on that just a little bit. Thank you, though, for a good presentation.
Good presentation. I like the way that you integrated Lynette's story into it, because it served as a good foundation for, what to talk of. I like the idea of involving patient in the care. It's one thing that we oftentimes forget about, is the patient oftentimes has a say in it, and that was good. It was innovative in my mind to really improve the workforce by hiring out of the unemployed. That was great. As I mentioned before, a little bit more understanding of the stroke risk factors on how you would go in and you had a good general approach, and in 20 minutes it's pretty tough to get down to the real specifics, but having more specific things might have improved the strength of that. As for your presentation, the big difference in your presentation is when you answered your questions, you were free-flowing, interactive, your voices went up and down, you were passionate. During the presentation, sometimes the level was sort of flat, no passion, more talking off the slides than out of your heart. So in presentations like that, the slides support, but it's your passion that's going to communicate what you're really good. So the questioning and answer, you nailed the questions. That showed great understanding, and your presentation was good. Comment to the gentleman, wearing a red tie is always important because it really focuses people on you from that standpoint. And the jewelry too. You paid good attention to each other. You weren't distracted. The big challenge in oftentimes these presentations, what to do with your hands. And so hands moved around a lot, sometimes get distracting for when we're looking, so just to pay attention to that, but it was a great presentation.
You guys did great too.